A primary misconception in addiction treatment is treating relapse as an abrupt, unpredictable failure. To effectively manage substance use disorders, clinicians must discard the idea of relapse as an isolated moment in time. The physical act of consuming a substance does not happen in a vacuum. It is the final manifestation of a behavioral and psychological progression that begins long before a person ever picks up a drink or a drug. Clinical frameworks map this unfolding timeline into distinct, progressive phases, tracing the deterioration of coping mechanisms from initial stress to eventual substance use. Recognizing this sequential nature provides a crucial advantage. It creates an extended window where clinicians and clients can identify warning signs and intervene. By viewing relapse as a gradual process rather than a spontaneous event, the counselor's role shifts. Instead of reacting to a sudden crisis, they can proactively monitor the behavioral precursors that lead to one. The process starts with emotional relapse. During this initial phase, the individual is not actively thinking about using the substance. Instead, their behaviors begin to set the stage for future use. The individual may start isolating from their support network, bottling up their feelings, neglecting their sleep and nutrition, and skipping recovery activities. If those emotional warning signs go unaddressed, the process escalates into mental relapse. This timeline visualization plots out the progression. We see the initial emotional relapse phase, marked by isolation metrics, and how they transition into mental relapse. In this second phase, a cognitive war begins. The client starts experiencing active cravings, romanticizing past use, bargaining with themselves, and even planning a scenario where they might use, all while attempting to rationalize it. Finally, we reach physical relapse. As the timeline expands, you can see that the actual instance of substance use is a lagging indicator. It appears far down the timeline from those first emotional triggers. The urge to use does not materialize out of nowhere. It is the direct, observable culmination of unmanaged emotional neglect and mental conflict. Because recurrence unfolds over this extended timeline, it generates observable behavioral data along the way. Clients can analyze their own past behavior to identify specific personal precursors, the exact emotional states, interpersonal conflicts, and neglected routines that reliably precede their cravings. They learn to map these patterns so they can act on early warning signs. But interception doesn't always happen perfectly, bringing us to a psychological trap known as the abstinence violation effect. When an individual committed to sobriety experiences a single lapse, one instance of substance use, they often experience severe guilt and a profound sense of failure. If unmanaged, this intense shame drives a full-blown relapse, motivated by the logic that the damage is already done. To preserve the client's self-efficacy and halt that cascade, clinicians must frame a lapse as an educational slip. Treating a temporary return to use as a behavioral error to learn from prevents a single mistake from destroying the entire recovery effort. Managing these risks requires moving away from acute, episodic interventions and toward a structured, skills-based protocol called relapse prevention. The first step in this protocol is mapping out the client's personal high-risk situations. This means pinpointing the exact people, specific locations, and precise emotional states that threaten their sobriety. Once vulnerabilities are mapped, the clinician and client develop targeted coping strategies for each risk. These strategies are actively rehearsed to ensure they can be executed under pressure. A central feature of this planning is drawing a hard clinical distinction between a lapse, a brief, isolated incident of use, and a relapse, which is a full return to prior chronic behavioral patterns. Establishing this clear boundary is a primary cognitive defense. It provides the intellectual framework necessary to stop a momentary slip from collapsing into total recurrence. Beyond cognitive strategies, effective prevention requires building a crisis-ready support network before any crisis actually emerges. This takes the form of a concrete, written emergency plan. It outlines the exact actions the client will take and the specific people they will contact the moment high-risk situations or cravings arise. A static document is useless during a craving. Prevention planning must be continuously updated as the client's circumstances change and dynamically rehearsed so the response becomes automatic. We see the need for specific, individualized planning clearly with justice-involved clients. For this population, returning to criminal thinking patterns or making contact with antisocial peers serve as unique warning signs that must trigger the emergency protocol. Abstract theoretical plans disintegrate under the pressure of actual cravings. Only individualized, actively rehearsed protocols hold up against high-stress triggers. Clinical treatment operates within a fixed time frame, usually lasting weeks or months. Recovery from a chronic substance use disorder requires a lifespan of management. To bridge this gap, clinicians must transition the client away from relying on the clinical setting and integrate them into durable external support systems. The counselor acts as an architect in this phase, actively guiding the client in constructing a personalized network of recovery support that will outlast formal therapy. This network cannot be prescribed from a standardized template. It must be dictated entirely by the client's preferences, cultural background, and logistical accessibility. To achieve sustainable recovery, the structural scaffolding of support must be successfully externalized, taking root far beyond the walls of the clinic. For many individuals, mutual help groups form the traditional cornerstone of these external recovery networks. The most widespread framework is the 12-step model, such as Alcoholics Anonymous and Narcotics Anonymous. These programs operate on principles of admitting powerlessness over the substance, relying on a higher power, conducting a searching moral inventory, and making amends. They are driven by specific structural components, including regular meetings, a culture of anonymity, and sponsorship, where an experienced member actively mentors a newcomer. This branching matrix categorizes support frameworks by methodology. Alongside 12-step models, we see alternative paths for those who do not align with that approach. These include cognitive behavioral programs like Smart Recovery, mindfulness-based models like Refuge Recovery, and secular organizations. Regardless of the group, counselors carry a specific responsibility to identify and counter any stigma regarding medication-assisted treatment. They must ensure clients on medications for opioid or alcohol use disorders find meetings that respect their clinical needs. The availability of diverse clinical pathways is mandatory. Adherence to a mutual help group relies entirely on philosophical alignment between the program and the client. Beyond formal meetings, the support ecosystem extends into the community through recovery community organizations and peer support specialists. These specialists leverage their own lived experience to provide credible, practical guidance. During the most vulnerable early stages of abstinence, recovery housing provides structured, substance-free living environments that stabilize clients when they need it most. These disparate elements are often organized under a macro framework known as a Recovery-Oriented System of Care, or ROSC. A ROSC coordinates both formal clinical treatments and informal community networks. The goal is to manage recovery over the long term, rather than cycling patients through acute, episodic care. Within this system, natural supports, family members, employers, and faith groups play a vital role in maintaining behavioral gains after clinical discharge. Clinical treatment is highly effective at initiating the recovery process, but it is this integrated community ecosystem that actually sustains it over a lifetime. Across all of these options, one core principle remains constant. No single support system functions universally across all demographics. The viability of any recovery network is dictated by a complex set of variables, including a person's cultural background, their personal spirituality, their gender identity, and sexual orientation. A client who is uncomfortable with spiritual language may thrive using the secular, cognitive tools of Smart Recovery. Conversely, a client from a highly communal culture may draw their greatest strength from a faith-based group. For clients who have experienced systemic discrimination, finding culturally safe settings where they are understood and protected is an absolute requirement for engagement. There is no single, scientifically superior support system. The best system is exclusively the one the client will actually engage with.